So we're up to question number 2 with this 32-month-old boy in the emergency room with abdominal pain. So remember, always look for new admissions notes, new nurses notes, new medications, new doctor's orders. Okay, Jennifer, welcome. Do you want to read the new part for us, please? And welcome, Sharon. You're great to be here. I'm
Sure.
glad you're here. Okay.
1200. Child alert and crying inconsolably at intervals. It's hard for me to read, it's a little small.
Let me see if I can make it
Okay, there
larger.
you go.
How's that?
Yeah,
Okay.
that's fine. Most noticeably when reporting abdominal pain is occurring. Pulse 120, respiration 20, BP 104 over 60, temperature 36.6, 97.9, pulse oximeter 98% on room air, nausea and vomiting present. Further assistance finds diminished bowel sounds in the right upper and lower quadrant with a palpable sausage-like mass on the right side of the abdomen. Pull up diapers removed to find traces of blood, tinged mucus like stool.
Okay, awesome. Thank you, Jennifer, for reading that. And I'm going to greet Sharon. Hi, Sharon. How are you?
Hey, Miss Ignacio. I'm sorry I can't turn on my camera. I'm at work, so I'm just listening.
Okay, that's okay. Thank you for being here. I'm glad that you're here.
You're welcome. Thank you.
Welcome. Okay, so since Jennifer read, Tanya, kind of break this nurse's note down for me. What are you thinking? What stands out for you?
Okay, so they still talking about the sausage, like I'm trying to figure out where did it go. The sausage like mass on the right side of the abdominal. Still it got traces of blood and the mucus stool. So we still talking about some type of GI issue. Um, his pulse is, I wonder if that pulse is high. I'm not for sure. Maybe not, because he's a child. But other than that, then his vitals look okay. It's
Mm-hmm.
just the pain he's having on his right side and the sausage like mass on the right side.
Yeah, he has diminished bowel sounds in the right
Oh
upper
yeah,
quadrant and the lower
quadrant.
which that means it's like a blockage in the upper GI system.
Okay, so great, great, great troubleshooting, right? Trying to figure out what's going on with your patient. And the fact that this patient has been crying this whole time, right? Inconsolably, he can't be consoled. That's going to elevate his heart rate, right?
Mm-hmm.
So that's something, to think about as well. That pain is also, we know, even most of the times we're working with adults, but that pain is going to elevate the vital signs as well, as far as the heart rate and the BP. So, okay, so you've got it. So you expressed some concerns. So now the nurse is going to conduct the initial patient assessment. Okay. And remember, the initial patient assessment is always going to be done by the registered nurse, right? But that's okay, because LPNs need to know what to look for as well. So for each finding, you're going to click to indicate if it's consistent with appendicitis, a bowel obstruction, intussusception, or pyloric stenosis. All right. So this may be a good time to kind of think this through. And I'm going to click whatever you all tell me to click. We're going to start with the nausea and vomiting, and tell me which one is it a characteristic of these conditions.
Well, based off of the rationale you gave, they said nausea and vomit could fall up under appendix,
Mm-hmm.
bowel. I don't know what this into. I don't know what that one is.
Intussusception.
Yeah, I don't know what that is.
Okay. So if this was NCLEX and you're like, man, I don't know what that is, what would you just, commit to
Try to break it
something?
down. Yeah.
Maybe, or your best educated guess, because if you're just like totally, excuse me, drawing a blank, then, I don't know if you can necessarily break this one down. But maybe also somebody from maybe Jennifer can help you. Maybe Jennifer has an idea. And I'm going to put something in the chat also.
I would guess because Interception, like I guess that's with like swallowing or taking something in, would be my guess.
Okay. Very good. Okay, so that's not a bad guess. And I'm going to bring a picture for you. I'm going to bring a picture. So once you see this, you're going to remember it for sure. Okay. All right.
Oh, inside another pod. Wow. Okay. I just forgot about. Okay. It can cause
Okay.
swelling.
So
Wow.
okay. And so what are some of the key terms that goes with interception?
So that's that sausage like mass.
Okay, that is the sausage-like mass, and that is that current jelly stool because it has mucus. So you know the cookies, they're kind of white. They're like a shortbread, and they got a strawberry on the inside. It's like a cherry on the inside.
Mm-hmm.
So that's what it makes me think of. Those cookies, when we talk about current jelly, that's what interception makes me think of. And I hope that did not spoil your love of those cookies if they're one of your favorites. But whenever you see that cookie now, you're going to think of interception. Okay, let me see, where was I? Okay. All right, wait. Oh, I've got too many things open. Here we go. All right, so
That then definitely you can click that one.
click yes. Okay.
Yeah.
All right, very good. What about pyloric stenosis?
I'm gonna say yes.
Okay, awesome. So now I'm going to ask you, I'm going to click it, but I'm going to ask you all, what is pyloric stenosis?
It has like some inflammation of something in the GI. I don't know if it's the upper part or some form of uncompetent envy that block food from entering. Yes, I remember this. Yes.
Okay, so I'll give you a scenario. Usually, when I think of pyloric stenosis, I think of a nurse receiving a phone call in the office. My infant is projectile vomiting, and they keep being hungry, and they're inconsolable, that kind of thing, because of this constriction. And I'm going to bring a picture through so you can see it. That sphincter, right, the pylorus is actually kind of closed, right? So when we say stenosis, there's a narrowing. So if the patient has aortic stenosis, the aorta is narrowing. And so whenever we have something that's supposed to have things traveling through it, if there's stenosis, that means nothing's getting through. Okay, so in this case, pyloric stenosis, right here, this opening is very narrow. So food is not moving from the stomach to the small intestine, right? The duodenum, which is the first part of the small intestine. So that's not going to be good. The pyloric stenosis, projectile vomiting, and I'm sorry, I'm giving you the answer, so let me stop talking. Is one of the things that you would see. And that is a question, like if you see it by itself, that they must come in and be seen immediately. Okay, not like, oh, I'm going to make an appointment for you. All right, so go ahead and keep looking. I'm going to try to close some of these tabs. Okay, so intermittent pain, what should I select?
I think that can go for all
Appendicitis.
of them.
Okay, so appendicitis, you say all of them. Okay, so appendicitis, yes.
Mm-hmm.
Bowel obstruction, interception. Okay, and pyloric stenosis, you say?
I wouldn't say that.
Okay,
I,
so
I wouldn't choose that because it's like projectile vomiting. So I don't know. I wouldn't choose that, but it possibly could be.
okay, so you say don't choose it. Okay, so I won't choose it. Okay. So sausage shaped palpable mass. Which one should I choose? Which ones should I select?
Bowel
I think,
obstruction.
yep, and yep, them two.
Interception.
Yeah.
Okay.
Exception.
Okay, mucus-like and bloody stools.
Definitely interception and bowel obstruction.
Yeah.
Okay. Decreased appetite.
Um,
All of them to me.
yeah. I would choose all of them.
Okay. Fatigue.
Mm.
All of them.
All of them. Okay. And then hypoactive bowel sounds.
Bowel.
Um, I would choose bowel obstruction and interception.
I would do pyloric too, because hypoactive bowel sounds. Hyper, mm, low bowel sounds. So they won't have much bowel sounds if they got a blockage from pyloric, right?
Okay. All right. So this is how y'all want it to be?
Yeah.
Sure.
Okay. Okay. Okay, great. All right. So let's look at each one step by step. So let's kind of talk about what's happening with appendicitis. So describe to me how your patient with appendicitis is going to present.
They bent over, because
Mm-hmm.
that help relieve the pain. They usually do feel like some type of nausea or like dizziness. Um, they usually,
Guarding.
yep, guarding, yep.
Okay, good. I'm thinking McBurney's point. Do y'all remember McBurney's point?
Yes.
I remember it.
Okay, so
That it radiates from somewhere else. Is at one point, but it goes somewhere else, I think.
McBurney's point, if I take the iliac crest and my umbilicus and I draw a diagonal line, I'm gonna go and I'm gonna bring you a picture so you can kind of see what we have here. Okay, so here's the umbilicus and here's the iliac crest. So it's right here. If you draw an imaginary line, it's like about halfway. And so what happens with McBurney's point is we are going to press down and then release, and it's going to hurt even worse when you release, and that's called rebound tenderness. Okay, so that's one of the big things with appendicitis, that if we get a positive McBurney's point test, that rebound tenderness, when we release, it hurts worse. That is a red flag that, okay, this is appendicitis. Okay. All right. So with appendicitis, there's not a sausage-shaped palpable mass, but there is nausea and vomiting. There is intermittent pain. Now, if the patient says it hurts, it hurts, it hurts, it hurts, it hurts, and then it no longer hurts, I am not happy about that because that tells me what?
It broke, it ruptured. Yeah.
Exactly. Excellent. Right. So that is great. So that you know that. Mucus like bloody stools, that's not the case with appendicitis. And decreased appetite, that is true. Fatigue, that is true. And they are going to have hypoactive bowel sounds with appendicitis. So and of course, again, this is usually, depending on how serious it is, it's an emergency kind of thing because I don't want the appendix to rupture. Because if the appendix does rupture, then I'm worried now about peritonitis, which is also known as hot belly. And you all are familiar with peritonitis?
Yes.
Yes. Okay.
Yes.
Okay. Let me just show a quick picture of peritonitis just in case, um, because peritonitis is known as hot belly, and the key for peritonitis is going to be rigid board-like abdomen, right? And so a ruptured appendix could be a reason why a patient may have appendicitis, ruptured ectopic pregnancy, abdominal surgery, but the blood fluid is actually is filling up their abdominal cavity. And that's why you have that distension and it's rigid, it's board-like. They will have a fever. And of course, if a patient is bleeding, then that's going to, they're going to be going into shock, right? So these are the things to know for peritonitis. Okay, now thing is, I don't want my patient's appendix to rupture because guess what? Then all this fecal matter is going to be spreading into their abdominal cavity. Now I'll have to worry about sepsis as well. Okay. All right. So that's all the things that will go for appendicitis. Any questions about that? Okay, let's look at bowel obstruction. Tell me, how would you express a patient with a bowel obstruction? What are the clinical cues? What does a patient look like to you?
Um,
They would look kind of loaded a little, bent over. I know they will have like cough of ground. They will have their emesis to be like stool or blood or anything, something like that.
Okay, so you said a few things. So, and you're on the right track, right? Bowel obstruction, that's that coffee ground emesis, vomitus, right? That, and it smells really, really bad. Okay, once you smell that, you will remember it. Okay. So let's talk about the bowel obstruction just for a minute because I want you to be able to understand everything that goes with each of these conditions. So a bowel obstruction can be an actual mechanical blockage. It could be stool, something is blocking the intestines, or it could be due to a paralytic ileus, like a patient that is post-surgery, post-anesthesia, maybe a patient that is taking opioid narcotics because we know that morphine, those kind of opioids can slow the peristalsis, right? And so Jennifer, you were right that malodorous fecal smelling vomit. It's coffee ground emesis. It smells really bad. So you mentioned the abdominal distension, okay? And constipation with failure to pass flatus, okay? And so you all already alluded to this. If there's a blockage, there's going to be hyperactive bowel sounds because it's like, okay, I'm trying to push the stools, trying to push the stools. Then there's the blockage. Past the point of the blockage, you're going to have hypoactive, maybe even absent bowel sounds because there's no movement there, okay? Because of that potential, that blockage that's there. This patient that has a bowel obstruction may be on NG tube to suction, right? Now I'm concerned about fluid electrolyte imbalance, that kind of thing, okay? So for bowel obstruction, they're going to have nausea, vomiting, intermittent pain. They're not going to have, a sausage-shaped mass. They're not going to have mucus, bloody like stool. We said the coffee ground emesis is what you're probably going to see. And the rest go with bowel obstruction. Any questions about that?
So would that be the best way to break it down? Is just go from the top to the bottom and
Yeah,
say yes or no?
I was going from like
Me too,
the
across.
side view, but it's more better
Um,
if you go from the top.
if that's how your brain works, and I'm sorry because I kind of led you in that direction. I didn't let you all lead me. So in the future, I'll try to let you lead me and how you break down the questions. But I think it's good that we're doing it this way so you can say, you know what, I'm going to do it this way if I get this kind of a question. Okay. So yes, I think that might be the best way, especially if your brain works that way, then yes. Okay. All right. Let's look at interception now. So you'll kind of had the picture, you kind of had an idea, and you chose everything for interception, and you are correct. Okay. So all of these choices are correct for interception. So let me just say one thing about interception. Remember when you were, hopefully you remember when you were doing maternal newborn or maybe even a peds, they were like that meconium, that first stool is so important that we want to make sure that it passes because that could be one of the signs that, okay, they didn't have their first stool, the meconium that's dark and tarry. That could be a red flag. Okay. All right. Sometimes interception can actually repair itself too. But let me not give any more information. Let's go to pyloric stenosis. So pyloric stenosis, they could have the nausea and vomiting, not the intermittent pain, not the mass, and not the bloody stools, and they actually will have an increased appetite because food is not being absorbed, right? They're going to be hungry. So it's going to be the opposite. They're going to have an increased appetite, but they will have fatigue and hypoactive bowel sounds. Okay. Any questions about this one?
No.
Okay, I'm going to put the rationale in the chat, and then I'm going to let you all guide me in how you answer the next one so I don't influence the way you process this
No,
question.
that was a good way of doing it. I like it that way better
Mm-hmm.
than going across. And if
Yeah,
you
Okay.
me
look at
too.
appendix and just look at it and say yes or no to it, instead of like when you go across, you're thinking, I checked too many boxes. And
Ah,
Yeah,
so it's
yeah.
better to go yes or no, up and down, than to me felt like or across.
mm-hmm. Okay. So
Yeah.
That way
that,
I can look at each thing, appendix, and think, is this an appendix sign? Do this belong under the appendix?
Yeah,
okay.
like a silent sentence. When you go straight down, it's like, okay, this is a silent sentence. Or instead of be like nausea, vomit, can it be this? Can it be that? Can it be that? So it was more
To
better
go,
if we go from like top to bottom instead of like side.
okay.
Yeah. So
And
we'll
so
remember to do that on the NCLEX.
yes, ma'am. And so this is kind of like a select all that apply, really, when you think about it, right? But it's like a select all that apply on steroids because it's four conditions. So it's like, okay, you have to know because they can say, oh, a patient is presenting with appendicitis. What are the signs and symptoms? So, but that's the same kind of thing, right? But they're fitting it all
Yes.
in one question. So it's actually pretty clever how they're doing that. Okay. All right, let's go to the next one. Okay. So, I'll let Tonya now. Anything new?
Mm, no new notes.
Okay, let me try to make it as big as possible. Okay, so this is now dragging and dropping. Okay, so Tonya, go ahead and read this one and tell me what you think.
Okay. Drag one condition and one finding to fill in the blanks of the following sentence. The client is most likely experiencing items appendicitis, bowel
Mhm.
obstruction, intusant, and or I can't say right now. Jesus Christ is in my head. Pyloric stenosis.
Yes. Okay, very good.
So the condition, I'm a, mm, I don't know. To me, it's a bowel obstruction.
Okay, so for you, it's a bowel obstruction. What do you think, Jennifer?
I would do interception.
So you would say interception. Okay.
Yes.
So here's the thing. So I know you can't go back on NCLEX, but
I
another
know. I want to go back and look at the one we had picked all the block boxes for.
yes. And so that's something. So you remember, you're gonna have that whiteboard, right, on NCLEX. So I would jot down some notes because you can't go back, but you can jot down some notes so you can say, you know what, based on all the blocks that I checked,
Mm-hmm.
I know that this is interception because it fits all of the signs and symptoms, right?
Mm-hmm.
So when I see this next drag and drop question, if they have one, I know that this is interception. And as evidenced by what findings out of
The
all of,
sausage shaped palpable mass.
yes, okay, excellent. Now, if they had those bloody mucousy stools, that would be another thing to choose, right? Possibly, but they don't have that because then you'd have to choose two things. But those are like the classic signs of interception. Okay, all right, and so they say it's the hallmark sign, sausage shaped. Palpable mass is a hallmark sign, or it's a classic sign, textbook sign that, okay, I know this is interception. Okay. Any questions about these drag and drop?
No.
Nope.
Okay. And again, use that whiteboard, make notes to yourself because you won't be
Mhm.
able to go back. Okay. And you can request new whiteboards. You can't, I don't think you can erase it, but when you get there, they're going to tell you, and you'll just get a new whiteboard and a new whiteboard and a new whiteboard. But that's, I think, how they're doing it. Okay. All right. So I'll go to Jennifer now. Jennifer, any new nurses notes?
Um, yes.
Okay. Please tell us
At
what's new.
at 12:15, the ED physician notified for assessment findings, physician suspected interception, and we'll be putting in orders for interventions for the client.
Okay, excellent. Now, I will tell you that the way this is set up, like the notes are like underneath each other, but I think because the way the NCLEX is set up, it's going to be tabs that are next to each other. So you have to actually click on that next tab so it opens up. So I don't want you to miss that. So make sure you're clicking so you can see the other tabs open up with any new information. Okay, all right. So, based on the physician's response, the nurse anticipates potential orders and nursing interventions. For each potential nursing or collaborative intervention, click to specify whether the intervention is indicated or not indicated to include in the plan of care. Okay, so what is this question asking you?
Is this something that you think the doctor will order concerning the patients above suspicious with the interception.
Yes, perfect. Okay, perfect. Okay, so Tonya, tell
So,
us, and so I'll let you tell me what to select or however you want to select it.
so I think the CBC is a standard one, so I'm gonna say yes.
Okay.
Um, PMP. I know you're gonna do a abdominal ultrasound. You probably gonna do. I think BMP is basic metabolism panel. I would select that one too. Upper GI, NPO status. And yes, you're gonna do an NPO status.
Mm-hmm.
Not indicated. Prone position. I don't want to do that one. So I'm gonna say prone position not indicated. And I think you do need to swallow for this kid to get this upper GI thing.
So you're
But
saying this is an upper GI?
oh wait, I don't really know. Where is it? Um,
Okay, so I think you do know where it is. So
oh,
what's happening with interception?
one is going into the other.
One of what?
The
The
intestine.
intestines.
Yes, specifically which intestines, because we have two, small intestine or large
Yeah,
intestine.
large.
The large intestine. So is that
Right.
upper or lower GI?
Upper.
Is it
I
up?
don't know where the large intestine is at. I think it's at the bottom.
Okay,
Don't you
so
say
it's
small
lower.
before large? Oh,
So I'm going to tell you that the large intestine is lower GI. So if we have a lower GI issue, we're going to go for an enema. So it's going to be a barium enema. But if we have an upper GI, meaning anything from the mouth to the esophagus to the stomach to part of the small intestine, that's going to be the barium swallow. Okay.
okay.
So just think
That's
about it.
not indicated.
Right. So barium swallow is not going to be indicated. And with the barium swallow, the patient is drinking the contrast of barium, which is white chalky, tastes horrible, and they're actually taking an x-ray at the same time while it's going down and they're examining to see if there's any abnormalities. The same can be done from a lower GI series, but now they're not swallowing, they're actually inserting the barium inside of the through the anus to see, okay, what's going on with the lower GI. Lower GI, think large intestine, think colon. Okay. All right. So is this the answers you all saying? Okay. Yep, these are all correct. So remember, the CBC is the complete blood count. That's going to tell you your red blood cells, your white blood cells. Basic metabolic panel, you chose correctly. And that's not a bad idea. Anytime a patient has nausea, vomiting, diarrhea, I'm always scared of fluid electrolyte imbalance, right? So that's a good choice, and I would expect it. And you knew right away we had to do that abdominal ultrasound because we got to visualize these intestines. Okay. And you were right to say NPO. Whenever there's a GI issue, we're thinking NPO, right? Because we need to let's figure out what's going on. If there's a blockage, if the patient's still eating, that's going to cause some complications. Okay. And prone position is not going to be the position that we place our patient in for this at all. We're going to have them in at least a semi-Fowler's, if not a high Fowler's position. We're going to keep them upright. Okay.
Let me
Uh,
ask one more quick question
yes,
about about the upper GI, the barium swallow. Would they actually give that to a child?
they could. They
They
actually
would. Okay.
They could. Now let's and you just made me remember something that I should make sure I tell you. With the barium swallow, remember this is barium, and so afterwards we have to flush. The
Flush it
patient
with
has to
water.
flush with water because and let the patient know, right? Patient teaching that your stool is going to be chalky white. Don't be alarmed. And if they don't flush right with water, that barium can get solid like cement in their intestines, right? And that's not good. So those are some of the things in case you see like a regular question that just with barium, that's a teaching. Okay. All right. Okay, let's see. I think Tonya, it's your turn. Anything new
Yes.
here?
Yes. So nurses note, 1250 child taken for diagnostic testing, 1325 testing confirmed diagnosis of in I don't know why I can't say this word right now. In interception,
Mm-hmm.
treatment plans to include an order for client to have an air enema. Okay, and then the diagnosis report, diagnosis ultrasound image notes a round mass with a target bowel and bowel appearance in the transversal plane. There is no apparent perforation of the bowel noted at this time. Appearance consistent with diagnosis of interception. Recommendation use of air or contrast fluid enema.
Okay, awesome. So so you did a great job there. Let's take a look at when I think of interception, I think of
Interception.
interception, like I think of football for some reason. I have no idea why. It just makes me think of it. So if that helps you to remember interception, I don't know. Um, so let's talk about these new notes. Okay. Um, so excuse me. So they're gonna have an air enema. Okay, so what exactly is the air enema?
So they're just pushing air inside the intestines.
Yes, and so when we think of interception, like say this is my bowel, it's folded on each other, right? And so if it's kind of like a balloon, if you think about, those long sausage balloons that they use like the clowns to make like dogs and different animals and stuff. So if it's folded on each other, if I put air in, it's going to pop out, right? And it's going to inflate. Now, of course, when we're doing that, we got to make sure that we don't perforate the intestines. So we have to watch very carefully. Okay. And that's what they're talking about, bowel in bowel appearance. Okay. And the transverse plane. So remember, the large intestine, it has the ascending colon, the transverse colon, and then the descending colon. So ascending going from inferior to superior on the right side, from right to left is transverse, and then descending from superior to inferior going down on the left side. So this tells me that, okay, where would they see this bowel is on the transverse plane. Okay, it's probably the transverse portion of the large intestine. Okay, so let's see. All right, very good. So we kind of broke that down. So, Jennifer, read this and tell me what I should check, please.
Um, Diagnostic testing returns, and the child receives a diagnostic of interception. What should the nurse teach the parent about the treatment plan, select all that apply? Oh my God. Um, a surgeon will explain the diagnostic procedure and any potential complications to you. I would say yes. Um, uh, Fluoroscopy is a type of real-time X-ray images that will be used during the procedure. I would say yes. Um, Parents are not allowed to be present during the exam. I would say no. A soft tube is inserted into the rectum, allowing air to be pumped through tube. I would say yes. It's general anesthesia will be used to keep the child asleep during the procedure. Um, I don't know about that one. Additional radiology images may be used to confirm that there are no um perf- per perforations in the bowel. I would say yes. Antibiotics will be prescribed after the procedure. Um, I don't know about that one. I'm thinking, I'm thinking yes, because had mucus and stuff in the stool, so I don't know about that one.
Okay, so you're saying to choose antibiotics or not to choose it?
Um, based on the nurse's notes,
Let's go back.
with the mucus and it's a blood tinge, I would probably say yes with antibiotics.
Okay. All right, Tonya, do you want me to choose anything else, or what are your
I
thoughts
think
on this?
the general anesthesia will be used to keep the child asleep during the procedure. I think that's a yes, because you can't have local, but you might could give them IV. But this
Yeah,
is
that's what I
a
was thinking, like
yeah,
general.
it could. He has to be out though. There's no way you can do this procedure while the
Yeah,
child is awake. So if you would put that one, and if they go under general, then the mother wouldn't. The parents are not allowed to be present during the exam, because they're going in the OR. But this is okay. I don't know. I would have to think this through. General anesthesia will be used to keep the child asleep during the procedure. This is a baby, so I would want you to put my kid to sleep. But general can be harsh because anesthesia administered might not be good due to the decrease in bowel sounds when they wake up. Unclick that. Let's just go with what Jen said.
yeah,
Unclick
because
it.
I don't, because it
Yeah.
don't seem like an
Yeah, I
invasive
don't think it would
procedure.
have to be.
So
Yeah, me either, Jen. I'm gonna unpick that one.
Okay, so I
And
deselected that.
yep, antibiotics will be presented after the procedure. Antibiotics. Why would you need antibiotics? You didn't preparate
because it was
nothing.
like mucus. So I
But
just
but it's only because of the blockage. But why would you need antibiotics? Why? I'm trying to figure out why would I need antibiotics? Why would I need antibiotics? Well, you are going into the body with a different thing. Would you be subjecting them? Okay, I wouldn't pick antibiotics, but it's up to I keep it because
Okay.
of Jen, but
Okay, so you
we
said keep.
can deselect it because I was like kind of
it's up
like
to you.
yeah no
But
that
why would
only
you need
only
antibiotics? I'm thinking
Okay.
antibiotics. It's to kill down the germs and stuff. So you can't. You're right, Jen. Like it's a invasive procedure. So usually they do prescribe you antibiotics after a procedure.
only because they had
Yes.
mucus and blood. So
Okay.
I
Get
would
Okay.
picky.
that's
I'm
only.
fine with that.
I mean, but we can leave it unchecked.
Leave it unchecked. Okay, so if this is
But
NCLEX, you would not check it. Okay, so
I
let
would
I
me
mean,
check it.
I would check it.
My
I would
last thing is
check
I
it.
would check it. I would
so
check it.
I would
so
check it.
I
let
would
me
check it. I might be wrong, but I guess I would check
okay, so let me ask you this. If you were in the hospital setting, excuse me, and you were giving your patient a soap suds enema, a hog enema, a mineral oil enema, would you give them antibiotics for that?
it. No,
No,
no. And that's what I'm
Okay.
thinking. Antibiotics is like when they open you up and can expose you to. I wouldn't.
Okay, all right, great. So, and that's what, because I know you were torn, like, okay, so antibiotics are used for bacterial infection. Now, just because mucus is there, that doesn't necessarily say that the patient has an infection, okay? Because we actually have mucus in the lining of our airway. We have mucus that's in our stomach, right? Actually, the lining of the stomach is thick mucus. That's why that hydrochloric acid doesn't eat away at the lining of our stomach. So it's normal to have mucus, but the problem is that it's mucus filled with blood, and that is the kind of the red flag, okay? Because we probably have mucus right in our stools, but we may not necessarily see it because of all the waste material. But we do, in a normal finding, is to have mucus in your GI system. That's like a normal finding because again, the stomach is coated with thick mucus, right? So, but let's look at each of these. So this patient, this, young child is going to have this procedure done, and it is a slightly invasive procedure. So a surgeon will explain the diagnosis, procedure, and any potential complications. So yes, this is true. And so these select all that apply, one of the strategies is like true false. So is this true? Yes, absolutely. The surgeon is going to do that. And the role of the nurse is to make sure that informed consent is scanned into the patient's record. If the patient does not understand, then the nurse has to call the doctor back, the surgeon back to re-explain it to the patient. Okay. That's not the nurse's job. If you're an RN or an LPN, that's not your job. That's the surgeon's job. Fluoroscopy is going to be that fluorescent dye, and that is going to be used. Okay. Parents are not allowed during the exam, and that is true. Parents are actually allowed, okay? Because parents may have to console that child because it's not every day that you get a tube inserted right into the anus to get to the rectum. So parents are actually allowed, okay? So that is not to be selected. So you all didn't select it, so that's good. And so a soft tube inserted into the rectum, allowing air to be pumped through the tube, that is correct. And this is not a general anesthesia, because, and I love what you said, Tonya. Tonya, you said general anesthesia is harsh, right? So for something that is a simple procedure that could be quick, we don't want to give general anesthesia because there's so many complications that could occur for general anesthesia. And we think, okay, does the cost outweigh the benefit? Now we're thinking respiratory, we're thinking this anesthesia is going to even further slow down the GI tract. Like we don't want that if we can avoid it, okay? So you're thinking what you were saying, I was just like, yes, she's got it. So we don't check that. Additional radiology imaging may be used to confirm that there's no perforations in the bowel, and that's true. Absolutely. And also the radiology is also going to see, is the bowel presentation still there, or is the bowel now in its normal place? Okay, so no antibiotics. Okay, any questions about this one? Okay,
No.
no. Okay, fantastic. All right, so this is the last one, and is it Tanya's turn now? I forget.
Probably so.
Okay, go ahead.
Okay, 1400. Is that where we
Okay.
at? Yes. Radiologist and tech. No, we did that one, right? No, we didn't. We need that one.
Yeah.
1400 radiologists and tech to perform air enema. Parent present holding child's hand during procedure. 1415, abdominal is distended, inconsolable crying, flack, 10 out of 10. Okay. You want to tell me what flack is again?
Yes, I'm going to bring up a picture because I figured you
Okay.
were going to ask me that. So when we think about the
Okay.
FLAC, that is the pediatric pain rating scale, right? So let me give you an image of the FLAC scale.
Oh, that's the
Especially,
facial thing.
so that's, you're thinking of the Baker Wong. Excuse me. I still have this
Oh,
persistent cough. So this is what we use for our younger
yep.
children that can't necessarily point to the emojis. So this is the FLAC scale, and it's definitely worth looking at because you could see this in just a standalone question. And I'm gonna let y'all look at that for a second while I bring up the Baker Wong. So again, this is for your younger patients that can't necessarily verbalize that they're in pain, okay? Now, I think, Tonya, you were thinking of the Baker Wongs, and I kind of think of this as like the original emojis, right? So, and this is for an older child that if you say, point to this one, how do you feel right now? Okay. So at 32 months old, they may or may not necessarily be able to point to this, but maybe they can, right? But also, if they're crying inconsolably, you're probably not even going to get their attention. But this is the Baker Wong's Faces pain rating scale. So I just wanted to make sure that you knew what the scales were in case you see it again. Okay, any questions about those scales? Okay, so the FLAC
So the
is
flack was based off of what the who
okay.
gave this 10 out of 10? The doctor? How did they get that 10 out of 10?
let me see, where did that come from? So this is the nurse. This is the nurse
Nurses know.
that
Also, the
provided.
nurse is saying that's after she evaluated him. She feel like he's a 10 out of 10. Okay. Because of
Yes.
the crying and stuff. Okay.
Yes. Yes. So for the face, quivering, clenched jaw, kicking, arch, rigid, jerking, steadily crying, inconsolable, difficult to console. So, okay. So yes, definitely 10 out of 10 for that little guy. Okay. Um, do
And
you want me to
each
go?
box is worth 2 points. That's why it was 10 out of 10.
Yes, let me go back because I think I probably went too fast.
No, it's okay. So each box is worth 2, 4, 6, 8, 10. All right, I got
Yes.
it. I understand now how she got the number. Okay,
Yes. Okay.
that makes
Perfect.
sense.
Okay, Jennifer, what about you?
I'm fine.
Okay, excellent. All right, so let's ask this question. Jennifer, you want to tell us what you think about this one, please?
The nurse remains in the room with the patient and parents after the procedure. Complete the following sentence by choosing from the list of options. The nurse determined that the client's status is, oh my God,
Improving, so improving, deteriorating, or unchanged?
unchanged. He got a 10 out of 10, so he was still crying.
Okay. Okay, let me see. And then the nurse should now, so you say the patient's unchanged.
Um, Page the gastrointestinal surgeon.
Okay. All right, very good. Let's take a look now. And I'm gonna ask Tonya what she thinks. So,
Okay. Well, I know I won't page the guy. I don't know if it's an order for pain medicine, but if it is, which it should be some form of standing order, I would definitely give the pain medicine. The nurse remains in the room with the patient and the parent after the procedure. Now, based off of the red tape perform it and my patient present holding mom's hand, they don't tell us no outcome about it. Let me see.
mhm.
It
Abdominal
said his stomach is still
is
distended.
distended, inconsolably crying, but it's distended because it's air in there.
He's
Maybe,
still crying. He a 10
maybe
out of 10.
10 out of 10.
So
I mean, they wouldn't have let him out if it was something hadn't improved. I mean, I know it appears the nurse determined that the client status is what unchanged. Client status is unchanged. Well, you can't say it's improved because he don't look like he's improved. And I can't say it's diminished. So I guess I would do unchanged, but my nursing I would do now is minister pain medicine. I don't know. I guess so. Let me see. Page the gastroenterology surgery. What was the other option?
For under unchanged, so is
Down
it
bottom.
okay?
Yeah.
So prepare patient for a second air enema. Oh, sorry. Administer oral pain medication. Page the GI surgeon.
As a nurse, I think I would administer oral pain medication. But I could be wrong because I don't have an order for it. So administer oral medication. But they didn't say they didn't order that for him. Okay, page the guy. Page him. I know I hate picking the surgeon one because you know how they never want us to pick that unless we do something first. Like, assess, implement, evaluate. So for me, the page, it's hard for me to pick that one. We assessed him in essence, going back to our nursing stuff. We assessed that his abdominal is distended. He's
Okay.
inconsolably still crying, and he's at a 10 out of 10. But that don't mean he's 2.5. That don't mean that, you know what I'm saying? It
Okay,
was
so
but
unsuccessful.
I would say page the surgeon because his condition is unchanged, and now what's some new orders? Because okay, that didn't work. So are you going to give new orders or give order for pain meds? You order say take a map for another session of the enema. So if I done all I can do and his condition is still unchanged with the assessment, then I would call the surgeon again.
Well,
okay.
yeah.
So let me ask you all this. Okay, so we were doing pretty good, right? We got the procedure done, right? So the radiologist and the tech, they performed this air enema. The parent is there holding the hand. The abdomen is distended, right, at 14-15, inconsolable crying. FLAC is 10 out of 10. So, yeah, we looked at the FLAC, but I'm going to submit to you whenever a patient's pain is a 10 out of 10, it's at the max, that is not a patient that is improving. Okay. This pain should, and I know that they didn't necessarily say what the pain was beforehand. This is the first time we actually have a pain assessment, like an actual number. But this tells me that this pain is to the max. Okay. So this is not a patient that is improving. In fact, it makes me think that they're probably getting worse. Okay. So let's take a look at the diagnostic report because that's new information. Diagnostic ultrasound imaging notes a round mass with a target bowel in bowel appearance. So the reason why we did this air enema in the first place is we wanted to blow it up like a balloon so we wouldn't have the bowel in bowel. But guess what? When they finish, this diagnostic report tells us that it's still there. Okay, that bowel and bowel appearance in the transverse plane is still there. But the good thing is that there's no perforation of the bowel noted at this time. Okay.
But we had that note already. We
Okay.
had that note prior. So do it still apply? It was never updated.
Um,
We had
okay.
that note. Jennifer wrote. I think I read that one.
You did?
Remember,
Okay.
use the air.
Okay, so maybe, yeah, so that's true. Okay.
So
Um,
is the procedure done? Was that evaluation done 15 minutes after the procedure?
I don't know. Gosh, I might have to go back. Okay.
Okay.
So, but the note is definitely new, right?
Yes,
The fourteen
that's new.
fifteen note. Okay,
The
so
1400 and 1415.
14, okay, so this is a tough one then. Okay. And so it's definitely not improving. And
No.
I don't know if I would say that it's unchanged, but I really feel like that pain, that, FLAC 10 out of 10 is a new finding. And that is causing me a concern. Like whenever there is a patient's pain that is a 10 out of 10, that's always a red flag, right? And so what I was telling my foundation students, right, that pain is the fifth vital sign and you've got to address it. You've got to ask some questions. Okay. Um, Let me see what this is saying. So the correct choice is going to be deteriorating. Okay.
Mm,
And I know it's hard for us as nurses to call the doctor, but if you have a patient and their condition is deteriorating and you have assessed, you have done everything that you can do, you've got to call the doctor. And I know probably at clinical, you've seen, okay, we're going to try all this before we call the doctor. The doctor hasn't slept in 36 hours, all those other things. But in the NCLEX world, if the patient is crashing or if, the patient needs more than what you can give them, then you've got to call the doctor. And so this is where you page the surgeon. So let's look at the other things. So when you all were saying administer oral pain meds, I'm like, wait a minute, this is a GI issue. Can this patient have anything by mouth?
right.
Yeah, so definitely
That's
no,
true.
right?
Hmm.
So never forget the system that we're in. And then prepare the patient for a second air enema. Well, we just don't do that on our own, right? We need to have a doctor's order to do that. Okay. So I would just do like, even if I wasn't sure, if I don't like to call the doctor, that process of elimination will tell me I've got to page the surgeon. And I think with this question, is this one that you would get like partial credit if you said page the surgeon and if you left it unchanged? This is 0, 1. I don't think you would have gotten any points for this one if you got one of them incorrect, I think.
I
So
think it was the pain which made me say unchanged because it didn't say nothing about pain in the admission notes and the nurse's notes. Only at the 14, 15. They never assessed about pain.
yes. And I would just submit to you, and if you see a question, if the patient's pain is a 10 out of 10, that's definitely not a patient that's improving for sure. Especially if we have already provided some interventions and we've done some, some procedure that's supposed to help with the pain, then that's a patient that is not improving. And this one was kind of hard because if you see a patient's blood pressure dropping, you know that, okay, this patient is not improving. Or if you see a patient's blood pressure getting super elevated, right, you know that that patient is not improving. They're at increased risk for heart attack and stroke. And I think it's also even harder because it's a child, right? And I know for me, pediatrics is really super hard. And then the FLAC scale, we're not really familiar with the FLAC scale. So that's another piece of it too. But I would submit to you, if you see this kind of information, just even as a regular question, a bow tie question, that you wouldn't get it wrong because now you understand. And I hope I wouldn't get it wrong either because now I understand. So it's deteriorating. Any questions about this one? Or let me see what the rationale tells us for this one. The distended abdomen and inconsolable pain could be indicative of a perforated bowel from the procedure of the air enema. Successful air enema should resolve pain, and distension should pass as gas from the client. This situation would lead the nurse to page the GI surgeon and prepare for potential surgical interventions. Okay. So that really says a lot, right? Because we were thinking that this procedure should help the patient, but it didn't. Okay. And that makes a lot of sense to me. Any questions about that one?
That required a lot of reading to to me it felt like.
Yes. And I don't think you'll see anything necessarily this detailed. You may see something though on the FLAC scale. That's totally within something that you could see. And but I think we also hit on a really important point is that it's okay to call the doctor, even if it's NCLEX. So another reason why you would call the doctor, and I'm going to stop sharing my screen for a second. Another reason why you would call the doctor or the physician is if you have an unexpected finding, something that's abnormal, something that the patient can suffer great harm from. That's another reason why. So if a patient has large clots of bright red blood in their urine, I'm calling the doctor. Okay. Yes. Okay. Bye, Sharon. I'm glad that you were here. Okay. Um, so let me ask you this. I know Sharon has to go. Do you all want to do another one, or we can save the other one for Thursday if you're able on Thursday? So I'm going to leave it up to you.
What you want to do, Jen?